clinical practice, when the physician made the decision, sometimes encounter the guideline gaps. As you see, professionally, when a patient suffered from coronary disease, also cerebrovascular disease and peripheral artery disease simultaneously, guidelines often address each condition in isolation. And what core principles guide your decisions in these guideline gaps? And do you prioritize the most dangerous scenario or plan care based on overall prognosis?
Yes, it's a very tough situation because patient situation is very complex. But one thing is absolutely right. Treat the most life-threatening situation first and then see how it's going on. For example, you have already mentioned if a patient has cerebrovascular disease, peripheral vascular disease, and coronary disease, which one should I focus on? I should say which one is the most important. And are there any conflicts between these two situations? For example, if a patient has a cerebral ischemia and a coronary disease and the peripheral artery atherosclerosis, it's fine, it's easy, because the treatments are quite similar. Antiplatelet therapy, lipid-lowering agent, that's fine. But if the patient has hemorrhagic cerebrovascular disease combined with coronary stent, that's the real thing we need to balance between situations. So in this situation, I would say the hemorrhagic, the brain bleeding is already happened. So that's the most life-threatening things. So treat the brain first. And we see how it's going on with the heart. The heart is a possible situation. It's not a definite. So I think just in general, if multiple things happens, treat the most life-threatening first. That's my philosophy.
Yeah.
So how about you?
No, I agree with you, what you just said. That was very wise. If you were to ask me what the most common error is in multivascular disease, polyvascular disease, it's in missing it. Not making the diagnosis. The patients I see with peripheral arterial disease are often missed.
Sure.
I mean, if a patient comes to their doctor and they're complaining of chest pain, the alarm bells ring, right? And that patient gets better care. If a patient comes in, they're having trouble walking, well, it's an older person, they may have a neuropathy, they may have joint issues, back issues, and their peripheral arterial disease is missed. We did, there's been a number of studies that I've been involved in. One is the old partner study, and in that study, that was quite a few years ago, that study, most patients with peripheral arterial disease were not being diagnosed. This was a screening study where we were looking for patients with coronary disease, with peripheral arterial disease. Most of the patients with peripheral arterial disease were not being diagnosed, and those that were diagnosed were not treated aggressively enough. And that was quite a long time ago. I thought when we published that was going to change the practice of our colleagues, but I'm afraid it hasn't. Peripheral arterial disease is continuing to be missed. And someone with peripheral arterial disease typically has disease in other circulations. So it is a life-threatening condition because they have coronary artery disease, they have carotid artery disease, they may have aneurysms. So I think, the first step is to put in place in your clinics a mechanism for detecting it. Ankle-brachial disease is an easy way to do it, measuring pressures at the ankle and doing the blood pressure. Was an easy way to detect peripheral arterial disease.
And thank you, Dr. Li and Professor Cook. And as you told us, the biggest problem when we encounter patients with a complex multivascular disease is missing. So is there a framework to guide clinicians when formal guidelines are lacking? Is there a framework?
Yeah, I think the American Heart Association has given us some great guidelines for the management of peripheral arterial disease, and so I think that, by following those guidelines, you'll be guided well. But my point is that you have to make the diagnosis first, and then once the diagnosis is made, those patients have to be treated aggressively. And they tend not to be treated as aggressively as the patients with coronary artery disease. There's documentation of that. Unfortunately, they're not getting aggressive management of their cholesterol or their diabetes. They're not getting walking programs. Antiplatelet, antithrombotic therapy. So these are life-threatening interventions, life-saving interventions that you can make in the patients with peripheral arterial disease. Statins, ACE inhibitors, angiotensin receptor blockers, antiplatelet, antithrombotic agents, good walking program. Stop smoking, of course, so you can make a huge impact on those individuals' health. Those are patients with polyvascular disease that you can really benefit with a good preventive medicine program.
I fully agree with you.
你好，中国，东方问道。